Bilkis Shabi, very young, dynamic, and vibrant Chairman Department of Medicine at King Edward Medical University. We are very lucky to have such a supportive and such a encouraging young head of the department in King Edward Medical University who supports the academic activities all the way. Thank you very much, Madam, for being there. I would also like to acknowledge our speakers for today. We have very big names in the field of medicine. We have from cardiology, Dr. Muhayyuddin, PSIM, very active in all our academic activities and always spares time to impart knowledge to our physicians here at PSIM. Thank you, Professor Bilal, for taking time out and delivering today's talk. I would like to thank our second speaker, Professor Shabeen Naz. She is a gynecologist and obstetrician at ISRA Medical University, Karachi. She has been member of IVF and presented at many talks in international conferences on pregnancy-related medical issues. So we are very glad to have her on board. She will be talking about pregnancy-induced hypertension. We have with us Professor Dr. Sajid Ubaidullah. He is my mentor. He's been my supervisor, and all of my career of medicine have been with him. So he will be talking about hypertensive urgencies and emergencies today, and you will love it. And then we have with us Professor Zahid Kamal. He is a consultant ophthalmologist. You know that hypertension affects every part of your body, and eyes are no different. So he will be talking about what effects the high blood pressure have on the eye and what pathologies you can see. And you know, eye is the window to your body. So what are the things in the eye that you look for in a hypertensive patient, and how eye is affected by the increase in blood pressure. Professor Zahid Kamal is also principal of Sahimal Medical College. He will be joining us shortly. I think he's still not here. We are just waiting for him. And last but not the least, we have the Dean of Institute of Child Health. He is the Professor of Pediatric Cardiology, a very big name in pediatrics, Professor Masood Sadiq, an excellent speaker, an excellent orator, and he will be delivering talk about problem of hypertension in pediatric age group. So without further ado, I would like to start our today's session. Thank you very much for all the wonderful responses that we got yesterday. We had a very good participation of about 350 people yesterday, which stayed till the end, and very timely they sent us the evaluation forms back. So we will be checking those evaluation forms on the end of day 3 and then awarding certificates according to the results. And thank you very much for being very good audience. There are just few suggestions. 1, keep your mics on mute. 2, if you have any questions, please write them in the chat box. The moderator will note it down. Most of your questions will be answered throughout the session because the talks will be addressing all the issues since this is A to Z of hypertension. But if there are any questions which are not addressed, we will be addressing them in the end of the session. And thirdly, to all the speakers, when you share your screen, once you are finished, please don't forget to unshare your screen. Thank you very much, and wishing all of you a very, very productive second session of Hypertension A to Z. Thank you.
Thank you so much, Dr. Soumya. Now we'll request Professor Dr. Bilal Syed Muhyiddin Saab, who is Professor and HOD of Cardiology of King Edward Medical University. He is also Chairman Scientific Committee on Hypertension Pakistan Cardiac Society. I request respected Professor Dr. Bilal Syed Muhyiddin to start the lecture first on hypertension cardiovascular disease.
Do you see my screen?
Yes, so we can see your screen. We can see you on the screen as well.
Yeah, that's the whole idea. I thought because this is a screen photograph taken with a friend in the cath lab, and that was well before the COVID days. So the idea was this is what I used to look like before the COVID days.
It's different, sir.
Right? So there is a difference. Okay. So hypertension and the CV issues that we are going to go through. There will be certain things that I will be saying which some people may agree, may not agree. There will be things that I would like you all to look into as I go along. And one thing that I'm going to ask you all as I'm going to go through it is to have your paper pencil with you, because there is going to be something over there for interest for all of you. So without much ado, I would say that let's start. Now let's see if this screen advances. Okay. There's nothing to disclose except that it's a happy Independence Week going on, and Independence greatness to all of you. It's indeed a pleasure and a privilege to be living in a country like ours. So I thought first we are just, you are discussing hypertension, so we must have a little bit of a history behind it. So William Harvey, back in 1578 to 1657, who described the circulation of the blood in his book at that time. And Stephen Hellas made the first published measurement of blood pressure back in 1733. Thomas Young in 1808, and especially Richard Bright at that time noted the issue of kidney disease along with it, and thus the Bright's disease came into being. And in 1850, George Johnson suggested that the thickness of the blood vessels in the kidney in Bright's disease might be an adaptation to elevated blood pressure. William Sensen Kirks in 1855 and Ludwig in 1856 also proposed, based on pathological observations, that elevated pressures could account for the association between left ventricular hypertrophy to kidney damage in Bright's disease. And Samuel Wilkes observed that left ventricular hypertrophy and diseased arteries were not necessarily associated with diseased kidneys, implying that high blood pressure might occur in kidney with healthy kidneys. And then Frederick Akbar Mahmood, very interesting name, in 1874, using a sphygmography, was able to demonstrate this fact. Later, hypertension as a medical was then in 1986 with the invention of the Korotkoff sounds-based sphygmomanometer was measured, and this allowed blood pressure to be measured in clinics. So this really became the big changer of the game for us. And Nikolai Korotkoff came up with the Korotkoff sounds, which we are even today using. Donald Dunn invented an accurate, fully automatic oscillometric sphygmomanometer device in 1981, and that is how things have been going on. And the term essential hypertension that we are using over here a lot was coined by Herbert Frank in 1911 to describe elevated blood pressure, which had no cause to be found. Now, can we mute the azan, or otherwise I'll have to come to a stop? Thank you. In 1928, at Mayo Clinics, this describes a syndrome of malignant hypertension and a very high blood pressure with severe retinopathy and inadequate kidney functions, which usually resulted in death within a year from stroke, kidney, heart disease, and kidney failure, something that we are all very well aware of. And thus the consequences of benign and malignant hypertension come up. But the interesting is by John, professor of medicine in Liverpool in 1931. He writes, there is some truth in the saying that the greatest danger to a man with a high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. So this is what back was then. And keeping this in mind, in 1837, Professor White suggested that hypertension may be an important compensatory mechanism which should not be tampered with, even if we were certain that we could control it. And he's a very important cardiologist, because later on he becomes the founder of the preventive one also. Charles Frederick in 1949, in his classic book, Disease of the Heart, stated that people with mild benign hypertension not to be treated. And please note that this mild benign hypertension is 210 by 100. Look at what we are now standing, and this is not a pressures that you like to have at all. And this was referred to as mild benign. However, the tide of medical opinion has been turning. It has increasingly recognized in the 1950s that benign hypertension was not harmless. So since then, rest is history, and we have moved on forward from here. So what is the concern of a hypertensive patient? First of all, the big question comes up always is, why me? Why am the person who has got this blood pressure? Of course, as yesterday I also pointed out, you have got your genes. That is the way you were born. You were born too early. You had shrunken kidneys. That will be discussed by Professor Masood Sadiq later on. So all of these things sort of combine into it, and your genes and your platform that gets into it. But is that all? What about your lifestyle? Your parents didn't have it. Your brother doesn't have it. Your twin at times doesn't have it. But you do. So you look into your lifestyle, and then we get into with our patients and discuss what kind of a diet are they taking, how salt-rich it is, Because, these fast food diets, they are very salt rich, and they are the ones that cause the problems over there. Weight, what kind of weight is the person carrying? Is the BMI well above the 30 that he has, or has he got it corrected down to 25? Or on the other hand, he's actually emaciated at his blood, and his BMI is below the 19 mark also. What is his sleep habits? Is he maintaining regular sleep? Does he get in between? People, elderly age groups, having prostate problems. One of the problems lie over there. So that is something that needs to be looked into a person very carefully when you're talking of hypertension with him. Similarly, what kind of a work environment are you? Is your boss good? Are you the boss yourself? Are you a type A personality? All these things have to be physician, not necessarily on first day, but definitely as the time goes on, this has to be discussed by you. So the next question everyone is interested to know is, how frequently do I need to come up? Do I need to revisit again and again? Of course, it depends on the readings at presentations, how good or bad they were, and that defines it. So for me, the simplest thing is that if it is 180 by 120, with an active or eminent target organ damage, if he's in the clinic, he goes to the hospital. If he's an outpatient, he goes to the hospital, to the indoor, to the emergency. And of course, you have to look into the fact, and I'm sure as we'll be discussing the hypertension emergencies and urgencies, you'll have this answer over there, better tackled. Between 180 to 120, no target organ damage. Every 7 to 15 days, the patient should be coming in. And make sure that you get your 20 to 10 down. As yesterday also pointed out, this actually gets your risk factors into half. That's why it's a 20 to 10 down. That has to be there, at least 20 to 10 down. 1 month, if BP is higher than 150 by 90, remember that all these medicines, all these lifestyle changes do take time. So about 2 to 3 weeks is your basic time that it is needed. Next, 2 months if BP is higher than 140 by 80, because you really want to bring it down. And 2 months if BP is higher than 130/80 and you have these kidneys, eye, or anything else also going over there wrong. And 3 months if BP is higher than 130/80 and there is no other organ involvement. With this, the target being that our placement is finally 120/80. And 6 monthly if BP is less than 130/80. This is where roughly we all want to be. And well-trained self-monitoring has a place in deciding when to revisit. This is something which must be now encouraged, keeping in mind the big burden of the disease, which just cannot be managed by the health professionals alone. You have to train people. So another thing always is, what is my basic workup that must be done? When I go to a doctor, what information I must carry? Remember, this is our thing. As I remember the days, and even today, you can end up with some very fancy investigations, but if you ask whether there is any albumin in the urine, the answer is never available. So get your basic urines done early. Cardiac evaluation, ECG is a must. This helps you to decide your therapy in many ways, also how to follow him up, and then echocardiography if it is needed. The whole of the cardiovascular systems many times can't be done, but the peripheral vascular disease, the ankle brachial index and evaluation, as was also pointed out yesterday, is something that needs to be done. And if that is suggestive, then a carotid Doppler must be planned, especially in the elderly. Renal workup has to be done, urea, creatinine, uric acid, electrolytes, etc. Ophthalmology will be discussed. It has got all those 4 lovely signs coming up. Neurological, neuropathies are there. So there, CT scan you may need to establish, because when your management issues, you may have problems deciding on. There are certain things that bring in the mind. Hematological workup has to be done. Lipids have to be done. And abdominal ultrasound is something which should be planned, and within 6 months to a year, it must be done in a fresh diagnosed hypertensive patient. Why manage? Risk reduction. Most important is stroke. For definite, it brings it down by 40%. As a cardiologist, this is what I'm telling my physicians, patients. So I am basically preventing you from stroke, my first part. And if they don't know stroke, what stroke is all about. Coronary artery disease importance has gradually crept up. There are stories which say only about 8%, there are others which say even 45% improvement. But about 20-25% atherosclerosis reduction takes place over here. And regarding other organs, also it has its importance that must be done. Diabetes has to be managed. Hyperlipidemia has to be managed. Tobacco abuse was mentioned. Cigarettes, pipe, shisha, niswar, the Karachi gift, gutka, all of these are tobacco abuse. And they have to be stopped. And of course, the lifestyle changes. That is why you have got this problem. You must manage it out quickly. What is my risk of MI or stroke? Now, this is the question that many people need to know or need to go in that direction. Risk is determined on the basis of the next 10 years, of course. If you are less than 10% probability, you are on a low side. If it is between 10 to 20%, you're on a moderate side. And if you are above 20%, you fall in the high group. And not just blood pressure, the other factors also have to be considered. This is something that you have to remember. Putting all of these together is a challenging, difficult, and not absolute science, and varies from primary and secondary prevention. So you have data coming up for primary, how to do that calculations, but as far as secondary prevention is concerned, that does not hit you over there. So, as I asked you all, please make sure that you have got a paper pencil now, because we are going to go through the Framingham risk assessment tool for both for men and women. Kindly note these things for yourself and come to an answer for yourself. Look at your age, whichever bracket you fall in, and put a mark over there. Ladies, if you are in your 40s over here, which Professor Bilkis is probably, so that is where she would be. For others like us, you are flirting somewhere over here. So note your mark where you are. Smoker, this is a bomb, and this is a key to it, because this is your only actual thing that you can just stop quickly. For ladies, those who smoke, truth about it, passive smoking is, if you are someone who has smoked 4 cigarettes in your presence, then you have had a cigarette. And I calculate my cigarettes as the number of cigarettes a person has per month. And from there, we can decide how it is. This whole business about pack years is nothing else but a method that has been devised by the companies to sell the cigarettes. There are packs which are 10 cigarettes, there are packs which are 20 cigarettes. It may be sound like that. So pack years is basically, rather than saying that he smokes 20 cigarettes a day, they say he smokes a pack a day. So that doesn't sound too bad as compared to 20 cigarettes. So you have to actually say goodbye to it. So put your number where you are. Total cholesterol, your age over here, and if you know your cholesterol, what it is, and then your score. Look at your score over here, what it is. By and large, usually our people are somewhere over here. So if you don't know your score, probably put about 6 or 8 over there for those who are in this age bracket over here. Next is for men. Your score similarly over here, and your HDL, and this applies to both. If you are above 60, you get a negative. If you are between 50 to 59, which is very rare in Pakistan, because usually we see less than 40 over here. And then those who know their systolic systolic blood pressures, for a girl, note your systolic pressures. Greater than or equal to 160, this is where you are. If you are on medications and not taking medication, and if you are taking medicines, then this is where you are. Notice that taking medicines and not being controlled is worse than not taking medicine, because that basically means you are under scoring the whole importance of it. Similarly, for men, this is where it is. Note your ones, and this is your total. Note your total. Now, this is your total over here, and this is your score, percentage risk. Do note that men cross into 20% mark, the high risk, while ladies are still at 3% mark. So this is the place where things are not too good. And you ladies are doing quite well up to a certain time, but then they have got different scoring systems, if you noticed. And this is what is there all the way. And finally, they also, of course, make it to the higher brackets if they're smoking away. There is no importance as far as given to diastolic pressures over here. But remember, this is the most challenging because to prevent one stroke, if your diastolic pressure is between 105 to 9 and you start getting treated and the rest is okay, you need to treat 333 patients before you can prevent one stroke. On the other hand, it is between 100 to 104, you will have to treat 666. And if it is between 95 to 99, while the systolics are 140 and less, you have to treat at least 200. This is especially important because now as the guidelines are taking this level below, so you have to be really conscious of the fact, look at what is going to happen to your patient's treatment necessary. Number needed to treat really increases from here onwards. Okay, there is this ACC Framingham risk factor calculator. And this is the one which is now most commonly used. And this is easily downloadable. This is, if you go to the Google site, type in this and click on this, and you will come across and you will see this. Note, as it is reads over here, that this is for primary prevention only. This is not for secondary prevention. So you have to manage it accordingly. Now, these are the things that you'll come up over here. You'll have age, you'll have sex, you'll have race, you'll have systolic, diastolic. Now, the previous one did not have diastolic. You'll have also over here LDL. They'll be talking about your smoking status, your diabetic status. These are good 13 things that they're going to be asking you over here, unlike the previous one, which had less. So, what is the risk in this 45-year-old non-diabetic with poor BP and lipid control? I put in 45, a male. We do not come in the white or the African American races, so we go into other. His blood pressure is badly controlled. His cholesterol is horrendous. And yes, currently he's also smoking. And unfortunately, he's taking medicine, yet he's not doing well. And he's on statins and aspirin. Sir, this gentleman is in a higher risk bracket who is about to get an MI in the next 10 years. So this is the one who really, really needs to be looked after. Now, by this, remember what we saw in the Framingham basic one. On the other hand, if I was only changed the sex from a male to a female over here, male may be 20.9, but the female over here is 17.1. So more towards the reality comes over here. So the female is not a protection. At this age group, you are actually getting into the same muck as we are. And what if this person was also a diabetic? He would have jumped from 20.9 to 36.3%. This is where the real bigger bugger starts coming in. And once BP has been controlled to about 140 by 90, his risk factor has dropped from 20.9 to 15.2. This is thus the advantage of remaining a non-diabetic male of 45, yet you have got his risk protected now. And if we drop it further, not hypertensive treatment. If we said he was not on hypertensive treatment, this was on hypertensive treatment. It was 13.1. That's the misnomer between these two. Lipid profile correction, bring it down to 140, 40 and LDL. It suddenly drops down further to 5.4, going into the lower bracket. Your risk has really dropped down. You're still about 4 times the optimal level. You get your BP further controlled. You drop it down to 2.8%. And now, as he quits smoking for more than 6 months, this one drops down to 1%. This was also over there earlier, but now I'm showing you that he is getting his pressure things controlled with pressures at 120/80 and cholesterol maintained. So he's got himself well controlled at the right level. And if by any chance he really gets his pressures very well controlled, which some people do, his profile risk actually says that he is 0.6 while 1.2. Thereby, he's half of what is expected. But as the years will advance, this risk will also go up. Rest of the things remain same, but it will go up. And he will make it to 19.7 by the time he's 79. But of course, still, he will be well below the optimal level. So note weakness in this scoring. There are certain things which are still lacking over here. Tobacco usage quantities have not been defined. Weight, heights, BMIs have not yet been incorporated. 1 kg, by the way, reduction can reduce 1.6, and as was yesterday pointed out, or 6 kgs. But the fact over here is that this weight reduction improvement actually somehow the other starts happening after 4 kgs, not earlier. So it's not like every 1 kg you're going to have this. You have to get first rid of 4 or 5 kgs, and then you start noticing a drop of weight coming up. And this is the incremental change that will then later on. Diet and salt usage. This is something that is not there. And by the way, though 2,300 milligrams, etc., if you get your sodium, I thought I'll put it in millimoles. So if you get it down to millimoles, because some people like it that way, you can reduce it by 8 by 5. And if you really get it down to 50 millimoles, it goes to 16 by 9 reduction is there. What are your non-pharmacological hypertensive cares? Of course, the aerobic exercise is there. Relaxation and meditations have great placement. And of course, that is what our prayers are all about. This is the thing that is always the tricky part. 0.5 to 1 ounce of ethanol, as was yesterday said, was pointed out. But please note, understand what 1 ounce is. It is only 29 ml. What is 29 ml? Look at the fact that your Coke bottle is about 200, 250 ml. That is what a glass of water is. So it's an extremely small amount of ethanol you may be taking, but that is where it is cut off. And you should not take, and it is, 1 is the upper limit, 0.5 is what it is saying. Basically a teaspoon is something like what you can have. Other diet changes did not make much of a benefit that were pointed out earlier, like calcium, magnesium, potassium, and such supplements. They did not show any major benefits over there. And how to adhere? Proper explanation to all concerned, patient and family regarding hypertension, its complication and targets. You have to explain what you want to achieve, and only then it can happen. Simple therapy, easy to follow, what we were talked about. Preferably once a day, maybe twice a day, but having things which are thrice a day, complex medications, these are always difficult to follow. Imagine yourself, if you have to take 4 or 3 drugs every day in your routine, it is not possible. So you do try and do whatever, but then your target over here is important. And if you have to go, you have to go. Affordability and cost is something which is extremely important. Something which may be affordable. Yesterday, she pointed out that we have got 6,000 rupees income nationwide, yet we are big smokers. Because cigarettes are not given out free. So if a person smokes about 50 rupees cigarette, which is roughly 1 packet of your basic cigarette, or actually it's about 70 rupees, so that is good 2,500 rupees being spent over there. So you have to explain to your patient. So keep a strict watch on efficiency of your medicines, side effects, need of titration, and a regular follow-up. This has to be done, and only then your patients will be able to do the needful in a better fashion. And strengthen the system regarding the health, personnel availability, and safety, thereby also saying that, for example, if you're not available, your friends and colleagues should be there. Like now in the COVID, you're traveling outside the country, make sure that you have got your medicines, you have got yourself connected with someone who is a health provider. Look at all the problems that people have had to face in this COVID scenario that is going on over here. And with that, I will say thank you. I think I've actually shot out my time by a good 5 minutes. Please accept my apologies, and thanks to all.
Thank you so much, Professor Bilal Syed Mohideen Sahab. I request my all of the next coming seniors to please give only 15 minutes presentation, because we are already short of time. Now I request my respected teacher, my mentor, Professor Dr. Sajid Ubedullah Sahab. He is Professor of Medicine at King Edward Medical University, and also the Vice President, President of Pakistan Institute of Internal Medicine, Punjab region. And I request him to start lecture on the hypertension emergencies and urgencies. Professor Dr. Sajid Ubedullah Sahab, Professor of Medicine.
Can you see me and hear me?
Yes, sir, we can see you and hear you.
Perfect.
Thank you. Assalamu alaikum and good evening. I am extremely thankful to Professor Azizur Rahman, my elder brother and teacher, for giving me an opportunity to talk to this very august gathering in the month of August 2020. So August and August, two combinations. Thank you so very much, sir.
Just sorry to interrupt you. Can you be a little bit louder? We can't hear you properly. A little bit louder.
I would like to dedicate this very small presentation, which I'd like to finish within time, as Haroon Bilal has mentioned, to all my teachers who have taught me right from the beginning till today, and whatsoever we all are due to our teachers. And here I will start by quoting the definition of hypertension, which one of our teachers told us, or we listened in our final year class approximately 35 years ago in 1985-86, and I can exactly recall the definition word by word, that hypertension is defined as elevated blood pressure above an arbitrary normal figure, which is prevalent for that definite age, sex, and race. And I think in 2020 and in coming next 20 years, this definition will still be applicable to the hypertension, although with some modifications. JNC 9, 10, 11, 12, up to 50, this definition will stay as backbone of hypertension. The global burden, yesterday Soumya has already discussed. The global burden of hypertension. Just few glimpses of this from my side. By 2020, the global burden of hypertension was estimated at approximately 1.4 billion and is likely to be substantially exceed 1.6 billion by year 2020. As far as death toll is concerned and the mortality is concerned, in 2016, the non-communicable diseases accounted for approximately 71% of deaths globally. And among these non-communicable diseases, 44% were due to some disease of cardiovascular system, and hypertension was one of the leading risk factor. This is from Journal of Hypertension 2019. And then three very interesting facts. The South Asian patients had higher rates of hypertension compared to the other ethnic groups. But the good news is that we South Asians and Chinese patients have a relatively low risk of death and developing cardiovascular outcomes compared to the white. And again, something which is always evident, women, they always win. Women with hypertension have a better prognosis than men, regardless of ethnicity. And I always say that the men have two things. One is hypertension and the other one is phi tension. This phi is from female tension. This may be in all areas. It may be your wife, it may be your daughter, it may be your daughter-in-law, or it may be your someone else. But the combination of these two leads to a relatively higher level of hypertension and complications in men as compared to female. And just before me, Bilal has already pointed out that the men are always at higher risk than females. So no offenses, all females, but this is what is going on. The natural course of disease, as Bilal already said, and I always mention कि जब भी कोई बंदा ऐसा आता है कि जिसको young age में blood pressure होता है, तो मैं उन्हें कहा करता हूँ कि आप लोग किसी गलत घर में पैदा हो गए. You have been born in a wrong family. आपके वालिद को hypertension है, आपकी वालदा को hypertension, and you are born with this issue. And as always, we see that disease is a multitude of hereditary and environment. And those who are genetically prone to develop hypertension, and again they are they are not controlling their body weights, they are not controlling their diets. When you get up early in the morning, the rooms are full of the cokes and junks and everything which children have brought with them, or they are takeaways or home deliveries. Then this is prone to happen. So those children who are born with genetics of being hypertensive, and they get suitable environment, they flourish for hypertension, they go for early hypertension, and at some stage of their life they develop established hypertension. Once they have established hypertension and they become, I call it as कि उन्हें समझ आ जाती है और वो बंदे के पुत्र बन जाते हैं, and they control their diet, they control their body weight, they change their lifestyle, they walk, they take their medication regularly, they follow up with their doctors and their physician regularly, they stay as uncomplicated hypertensive for life. But if still they are not able to understand, then the complications they start, and they start involving different target organs, like the person may have accelerated malignant course, or heart may be involved, the large vessels may be involved, the brain may be involved, and the kidneys may be involved, and these all are the organs, target organs, which may be involved ultimately to develop some sort of target organ damage. This is same representation of what we have discussed just before. The high blood pressure leads to complications in brain. 24.5%, more than 24% people, they may have cerebral strokes. 16% or more, they may go into hypertensive encephalopathy at any stage of their life. The retinopathy, then their MIs, cardiac failures, cardiomyopathies, and chronic renal failure, approximately 10% of these people. Who are at high risk? Which organs are at high risk of development of end organs failure? Those which are having a greater reduction in the amount of cardiac output which they receive, those who have a higher oxygen consumption, those who are dependent on autoregulation. Examples are, for example, the brain, the kidneys, the heart. These are all organs which may be requiring some more oxygen, some autoregulation, and if these are deranged, then target organ damage, it occurs. The hypertensive crisis, these are acute, severe elevations in blood pressure that may or may not be associated with target organ dysfunction. Broadly, we divide them into two classes: the hypertensive urgencies and hypertensive emergencies. And in case of hypertensive urgencies, the systolic blood pressure may be above any figure above 180, and diastolic blood pressure more than 120. And these patients, they are not having any end organ damage, and they don't require hospitalization, they don't require intensive care facilities, and their blood pressure lowering therapy should be within hours, and usually they are adjusted on their oral treatment with some addition and adjustment, and in most of the cases parenteral therapy is not required. On the other hand, in those who are presenting with hypertensive emergencies, the blood pressure may be in the same range as is in hypertensive urgency, that is systolic more than 180 and diastolic blood pressure more than 120, but there is a definite evidence of end organ damage. These patients, they do require admission to intensive care facilities, and some of them require very quick lowering of blood pressure, and most of them they require parenteral therapy to lower their blood pressures. The risk factors for hypertensive crisis, they are approximately same which we have discussed previously as well, and these are the ones which are for uncontrolled hypertension, like female sex and pregnancy if they are developing eclampsias, higher grades of obesity, as Bilal has already mentioned, but does not correct himself. The mental illnesses, collagen vascular diseases, some intoxication, withdrawal symptoms of few drugs like beta blockers, and then drug-drug interactions like MO inhibitors, etc. But the most important one, which I'm sure everybody will agree with me, all over the world, is non-adherence to antihypertensive medication. I will be just giving you this figure to show you that in the US, where the patients, they are insured and they don't have to spend even a penny from their pocket as far as their treatment is concerned once they have paid their insurance. In even that area, 31% of insured adults with hypertension, they are non-adherent. You can see the non-adherence here in red and the adherence in green. You see that in earlier age group like 18 to 34%, 58% or more, they are non-adherent. And when they become relatively more adherent, you can see the best one is in approximately 65 to 75 years of age. यहाँ पे मैं एक बड़ी जो बात जब मैं देख रहा था स्लाइड को सोचा, मैंने कहा जब बंदा इस एज ग्रुप में आता है 65 to 74, तो उस वक्त बंदे के पास दवाइयों के अलावा बचता ही क्या है। अजीज साहब को भी पता है कि जिस वक्त ऐसे लोग आते हैं तो अपना थैला उठा के लेके आते हैं और उस थैले में जिसमें कई किलो मेडिसिन होती है, वो बड़े फख्र से आपको दिखाते हैं कि मैं ये भी दवाई खाना, तो मैं भी दवाई खाना। सो एट दैट एज adherence is maximum, and in young where they should be having best adherence, at that time they are having relatively low adherence. So this is all in that area which is so-called most civilized part of the world. What about us? What about us? Where our figures are present? I will request Professor Hafiz Chaudhary and Professor Bilal that can they give us any estimate later on at the end of this session in Pakistan, what is the percentage of non-adherence? So I think we can reverse it. It's even more than that. So the best thing is the most important risk factor till now, which I can understand, is non-adherence to the treatment, and this is ultimately leading to hypertensive urgencies and emergencies. The pathophysiology is very simple. The blood pressure, increased blood pressure, leading to autoregulation failure, increased vascular resistance, increased vasoconstriction, and then a cascade of prothrombotic state, some endothelial injuries, and then RAS activation leading to ischemia, and ischemia ultimately ending up with target organ damage. So this is how it is happening in all those target organs which we have already discussed. And this is important, that once a person has ended up with some sort of hypertensive emergency, and even then is not adherent to the treatment, then 1 year mortality is more than 79%. And survival is 10.4 months of these patients if they are not treated with antihypertensive drug therapy. So this is so important that once a person end up with hypertensive emergency, should be very, very adherent to the antihypertensive therapy. The treatment algorithm, although looking a bit busy, will be splitting it into different components. Very small discussion on it because it has already been discussed and will be discussed in coming time. A person presenting with hypertension, and when present to you, you have to see one thing, that whether he is having some end organ dysfunction present or not. If not, he is having urgency. And if having urgency, you can readjust the dose and you can discharge and follow. And if a person is having end organ dysfunction, ideally should be admitted and should be given treatment in ICU settings. And then depending upon which system is being involved, whether it is CNS, renal, cardiopulmonary, or obstetric, you can specifically give the treatment. In case of CNS, the person may be presenting with the ischemic strokes or intracranial hemorrhage or hypertensive encephalopathies, and again, it all depends that what is your target, what is your task. For example, in ischemic stroke, if we are going to thrombolyze our patient, then we have to reduce his blood pressure to less than 185 to 110. And those who are not the candidate for thrombolysis therapy, in that you can reduce them to less than 220 to 120. In intracranial hemorrhage, on the other hand, if there is hemorrhagic stroke, you have to reduce blood pressure a bit more drastically to less than 140. And in subarachnoid hemorrhage, again, you have to reduce it to less than 160. This is individual variation in the management of different emergencies. In case of renal disease with acute hypertensive nephrocalcinosis, you can offer few treatments, but the goal is to reduce blood pressure by 10 to 20% in first hour, and then reduce additional 5 to 15% or to less than 160, 110 in next 24 hours. In case of cardiopulmonary, with patients having acute coronary syndrome, acute heart failure, in those, the same formula will apply. The same formula will apply that in first hour, reduce blood pressure by 10 to 20%, and in following 24 hours, reduce additional 5 to 15%. But if a person is having aortic dissection, then there will be an emergency, and you have to decrease blood pressure immediately to around systolic blood pressure to around 100 to 120 millimeter mercury with a heart rate of less than 60 beats per minute. And in obstetric emergencies, in preeclampsia or eclampsia, the goal is to immediately reduce systolic blood pressure to less than 150 and diastolic blood pressure to less than 80 to 100 millimeter mercury. I will be in the next slide and the subsequent slide, which will be the last slide. I think these are the ones where we have to concentrate. These are the most important ones and also the take-home messages. The recommendations for hypertensive crisis and emergencies, the class of recommendation in all these three is one, the level of evidence is non-randomized data and consensus of expert opinions in all. And the recommendations are that in adults with a hypertensive emergency, admission to an intensive care unit is recommended for continuous monitoring of blood pressure and target organ damage, and for parenteral administration of an appropriate agent. So this simply means that whenever you come across hypertensive emergency, which we have very clearly defined, then the person must be admitted and should not be managed outside hospital or outside intensive care settings. For those adults with compelling conditions were few, as we saw in previous slides, aortic dissection or severe preeclampsia, or where you need to thrombolyze your patient, or a person is having subarachnoid hemorrhage. In all those compelling conditions, the systolic blood pressure should be reduced to less than 140 millimeter mercury during the first hour, and less than 120 millimeter in the aortic dissection. So you have to decrease in compelling condition blood pressure relatively drastically lower down, and it should be 140 millimeter mercury during the first hour and less than 120 millimeter mercury in aortic dissection. And for those adults who are without a compelling condition, the other all which we have mentioned, the systolic blood pressure should be reduced by no more than 25% within first hour. Then if stable, to 160 by 100 millimeter mercury within next 2 to 6 hours, and cautiously to normal during the following 24 hours. So 25% within first hour, and then cool down your patient, and bring blood pressure to near normal in following 24 hours. And this is the recapitulation of the same and take-home message, that a patient presenting with systolic blood pressure more than 180 and diastolic more than 120, see for target organ damage. If there is no target organ damage, patient is having hypertensive urgency, there is marked elevated blood pressure, what you are supposed to do, readjust the dose, add another dose, ask your patient to comply with the treatment, tell them to reduce their body weight, change their lifestyle, and arrange a very decent follow-up, as Bilal Muhyiddin has already mentioned. And if target organ damage is present, the person is in hypertensive emergency, then you must admit to ICU. It is a class 1 recommendation. And those who come up with compelling condition like aortic dissection, severe preeclampsia, eclampsia, or pheochromocytoma crisis, etc., their systolic blood pressure must be reduced to less than 140 during first hour and less than 120 especially in case of aortic dissection. And in others where there is no compelling condition, then reduce blood pressure by 25% over first hour, and then to 160 by 100 over next 2 to 6 hours, and then to normal over next 24 to 48 hours. With this, I thank you all for your very patient listening. I'm sure I haven't crossed my time quota of 15 minutes. Thank you so very much, sir.
Assalamu alaikum. Thank you so much, sir. Respected Professor Dr. Sajidullah Sahab, my teacher. Now I will request Professor Dr. Shabeen Naz Masood Sahaba, who is Professor and HOD of Gynae Department at ISRA University Karachi campus. She is Executive Member of Diabetes in Asia Study Group, and I will request her to please deliver lecture on hypertension and pregnancy. Professor Dr. Shabina Naz Masood.
Assalamu alaikum, madam.
Assalamu alaikum. Can you see the screen?
No.
Yes, ma'am.
We can't see her screen is not being shared.
Okay, let me see. Am I allowed the sharing?
Yes.
Mr. B, you need to
No.
open up the presentation on your desktop. And
Yeah, that's what I did.
Yeah, that's a share screen icon on the bottom. It's green
Yeah.
color. If
Now, can you
click
see
it,
the
it will-
screen?
No, cannot assist.
Still not? Okay. Okay, let me see then. That share screen.
Is your presentation open in the background
Yes.
on the desktop?
Yes.
Now we can share your screen.
Now, can you see?
Yes.
It's loading.
Double click, madam, double click. Please double click on the screen.
Yeah, but can you see the screen?
Yeah,
we can
we
see
can-
that you have started share screening.
Yes.
Yeah,
we
now
can.
we can. You have to
No,
go back.
sorry.
Yeah.
Okay. So, Assalamu alaikum, everybody. And I am very much thankful to PSIM team and Professor Aziz and everybody to give me this opportunity to share my talk on hypertension in pregnancy. So this is the first slide, how to attend online class. So step 1 is mandatory for everybody. Step 2 is optional. And while step 3, I think all the speakers and organizers would like to follow after the talk is over. So doctors, students, postgraduates, please follow step 3 after the program is over. So we'll be talking about management of pregnancy with pre-existing and gestational hypertension, and also management of preeclampsia, breastfeeding, and follow-up things. So talking about the frequency or incidence, globally, 1 in 10 pregnancies have hypertensive disorders, and it's a major cause of maternal mortality, almost 60,000 deaths per year. And in Pakistan, hypertensive diseases in pregnancy rank among the first 3 most common causes of maternal deaths. Actually, it is second in number after hemorrhage. And the frequency of hypertensive disorders in pregnancy is reported as 15% from Pakistan. So it's the second most common cause of maternal death after hemorrhage. And considering the prevalence of hypertensive disorders in pregnancy, it may affect the cardiovascular health of 300 million people worldwide. So why hypertension during pregnancy needs to be discussed? Because it has maternal effects, fetal effects, and not only this, but it has effects in later life. So as it's very rightly said, that when a woman is pregnant, she is also pregnant with her grandchild. And hypertensive diseases are conditions with a heritability of approximately 55%, which is contributed to both by maternal and fetal genes. And exposure to maternal hypertension has lasting effects on cardiac and vasculature system and functions. So fetal outcome in gestational hypertension again is not very good, and it is one of the important causes of perinatal mortality and morbidity, intrauterine fetal growth restriction, neonatal deaths, and prematurity. So is there any association of maternal hypertension with offspring blood pressure and cardiometabolic health in future? So a systematic review found that fetuses exposed to maternal preeclampsia and higher systolic and diastolic blood pressure during childhood and young adulthood have increased risk of cardiac disorders as compared to those who are not exposed during pregnancy with high blood pressure. So hypertension in pregnancy, pregnancy is divided into two halves. Like pregnancy comprises of 40 weeks of duration. So if we talk of first 20 weeks and a woman is said to have hypertension, then she is likely to have pre-existing high blood pressure. And if she develops hypertension in the last 20 weeks and is confirmed and last 20 weeks and is followed by and is also accompanied with proteinuria, then she is said to have developed a preeclampsia. So summarizing this, a woman with hypertension, if she presents before 20 weeks of gestation, and she may be considered as having pre-existing hypertension. But if she develops proteinuria also, then she'll be considered as preeclampsia superimposed on chronic hypertension. But however, if she develops hypertension after 20 weeks of gestation and without proteinuria, so she will be considered as gestational hypertension. But as soon as she develops hypertension after 20 weeks of gestation and develops proteinuria as well, she'll be labeled as having preeclampsia with its devastating complications, neurological complications, and eclampsia. So actually this part of the hypertension in pregnancy, that is preeclampsia and eclampsia, are the things that needs to be discussed. So guidelines for the measurement of blood pressure in pregnancy are very important. And as we already have discussed yesterday also, that women should be made to sit with the feet touching the floor, remove tight clothing, ensure arm is relaxed and supported at heart level. So how it is different from the blood pressure that we measure in non-pregnant women? So the use of cuff of appropriate size, that is 1.5 times the circumference of arm. Inflate cuff to 20 to 30 mm of mercury above palpable systolic blood pressure. Lower column slowly by 2 mm of mercury. And read blood pressure to the nearest 2 mm of mercury. The most important thing is that measure diastolic blood pressure as it disappears, as the disappearance of sound, that is phase 5. Sometimes we may take phase 4 as the diastolic blood pressure. And if blood pressure is consistently high in one arm, the arm with higher values should be used for all blood pressure managements. And all these recommendations are from the NICE guideline or European Society of Hypertension guidelines. White coat hypertension has a more favorable outcome than sustained hypertension diagnosed as ambulatory blood pressure monitoring. One very important thing is nocturnal hypertension is higher in women with preeclampsia than in those with gestational hypertension and is associated with more maternal and fetal complications. So nocturnal hypertension measurement is very important. And the predictive accuracy of ambulatory blood pressure monitoring remains low. So a high index of suspicion is required in pregnancy because majority of the women are asymptomatic. So detailed family history to confirm genetic basis for primary hypertension is required. And so is the examination, fundal examination, as we'll just be listening to our next colleague, to exclude hypertensive retinopathy. So definition of hypertension in pregnancy is if diastolic blood pressure is more than 110 on any occasion. And if systolic blood pressure is more than 140 and diastolic more than 90 mm of mercury on 2 or more consecutive occasions, 4 hours apart. So just one reading and don't label the woman as having hypertension. And proteinuria is assessed in hypertensive disorders of pregnancy. This is again important, that this dipstick urine analysis of more than 1 gram. And the most important thing is spot diagnosis, spot protein test, that is protein creatinine ratio and albumin creatinine ratio. They have high sensitivity and specificity. And here the cutoff is 30 milligrams per mole is significant, and protein creatinine ratio is 8 milligrams per millimole. So either of the two may be done. Both of these are not required. So this is an easier test to do, and report is available in just few minutes. So previously we used to do 24-hour urine for protein and first morning urine void and 2 clean catch midstream. So now these are no more being done. Now, as we know that this is ischemic injury and endothelial damage, they are responsible for most of the manifestations of preeclampsia, which leads to intrauterine growth restriction. If it comes to placenta, then liver, HELLP syndrome, lungs, pulmonary edema, heart. Heart has different manifestations, and cardiac remodeling is one of the very important consequence or adaptation. Then comes the kidneys, and most important is the brain, where the manifestation of intracranial vasospasm, ischemia, or eclampsia, which is a devastating condition and is responsible for most of the maternal deaths. So how to manage hypertensive disorders of pregnancy? Management of chronic hypertension in pregnancy requires pre-pregnancy advice. So that includes weight management, lifestyle, exercise, healthy eating, and lowering the amount of salt in their diet. But please remember that lowering the amount of salt in their diet is a pre-pregnancy advice. In pregnancy, we do not ask the women to lower the salt in their diet, but only to avoid extra salts. Likewise, as discussed yesterday also, that AC inhibitors, ARB blockers, and thiazide or thiazide-like diuretics must be replaced if the woman is planning to get pregnant with some safer antihypertensives like labetalol or nifedipine. Now, there are certain risk factors, and this must be taken into consideration. Like if the woman is having booking proteinuria, multiple pregnancies, or pre-existing hypertension, renal disease or diabetes, or antiphospholipid antibodies, then these women must be advised with more than one risk factor, the risk factors that I just enumerated for preeclampsia, to take 75 to 150 milligrams of aspirin daily from 12 weeks until the birth of the baby. But please do not start before 8 weeks of pregnancy or before the fetal hearts are visible or audible on ultrasound. So after 12 weeks and until the birth of the baby, the dose may be 75 milligrams or it may be 150 milligrams. Now, pregnancy with pre-existing or gestational hypertension, even if it is mild hypertension and sustained rise in blood pressure from 140 to 90 mm of mercury or accompanied with proteinuria, then this needs treatment. Obviously, severe hypertension will be considered as 160 to 110 mm of mercury. So management of hypertension in pregnancy is almost the same except for few differences. We do not offer bed rest in hospital. Most of the people I've heard saying that please take rest so that your hypertension goes away. Only bed rest is indicated if there are obstetric reasons for bed rest. Otherwise, the first line of treatment, previously we used to give methyl-dopa to all women and considered it as the safest drug. But now, according to NICE guidelines and many other guidelines, labetalol is the treatment of choice, is the first drug of choice to be given in pregnancy, or nifedipine, and the third line of treatment will be methyl-dopa, or first line of treatment may be methyl-dopa if labetalol and nifedipine is not tolerated. But remember that Lasix or diuretics have no role to play in control of blood pressure or edema. Now, after the drugs are started, target blood pressure during antenatal period when using antihypertensive medications should be 135 upon 85 mm of mercury. Obviously, the diagnostic levels are higher, but the control values need to be lower. Now, when and whom to suspect for preeclampsia? So preeclampsia, as I told earlier, new onset of hypertension, more than 140 to 90 mm of mercury, after 20 weeks of pregnancy with the coexistence of proteinuria and edema. So who are the women who are likely to develop preeclampsia? So the risk factors are first pregnancy, multiparous woman who had preeclampsia in any of the previous pregnancy, and the last one is 10 years of age. Elderly woman, obese women, family history of preeclampsia in sisters and mother, or a multifetal pregnancy. These are the women who are likely to develop preeclamptic toxemia. And if we want to know some predictive tests, then placental growth factor based testing is suggested to be predictive. And this test can be performed between 20 weeks and up to 35 weeks of pregnancy. The cutoff is, if it is less than 12 milligrams, test is positive and highly abnormal. Since it is a placental growth factor, so if it is more than 100 milligrams per picograms per ml, then the test is considered as negative and normal. So remember that this is a predictive test, but still it has not been validated and it's not highly recommended. But in high-risk patients, we can go for this test depending on the availability and the cost. So I just wanted to share a clinical presentation of Mrs. X, 19 years of age. She was primigravida, presented at around 8 months of pregnancy, that is 34 weeks of gestation, with symptoms of frontal headache, visual disturbances like stars twinkling and blank visual spots, severe epigastric pain and vomiting, and sudden swelling of extremities. Her mother-in-law said that this is a normal package of pregnancy. And she has these symptoms as there were guests in the house and she had to work too much and she slept late last night. The mother-in-law said that she herself had 10 children and never cared and rushed to doctors for these minor complaints. So according to mother-in-law, these were minor complaints. On clinical evaluation, there was severe pitting edema on dependent parts, sacral, hand and face. Epigastric tenderness was present, patellar reflexes were exaggerated, clonus was present, and blood pressure was 150/90 on repeated examination. Her investigations show a high creatinine value, raised allelin transferase, and platelet count was low. Uric acid again was high, it was more than 7 milligrams per dl. Concerns were about development of eclampsia, pulmonary edema, and fetal compromise. So magnesium sulfate was started as one of the following features of severe preeclampsia was present, which I just told you in the symptoms. that is recurring severe headaches, visual scotoma, nausea, vomiting, epigastric pain, and oliguria. And the lab investigations also were not conducive. So the regimen of magnesium sulfate was started. The easiest regimen to remember is this intramuscular regimen. In our women, we give 4 grams intravenous loading dose. In the books, you will find it as 5 grams. But because our women are relatively thinner and less, they have low stature, so we give 4 grams intravenous loading dose, and immediately followed by 4 grams in each hip. That means 8 grams total. 4 grams intramuscularly every 4 hours in alternating pattern. So this is the 4 grams regimen has to be remembered. You can find the dose in the books, but in the books it is given as 5 grams. And remember that if the woman has had an eclamptic fit, the infusion should be continued for 24 hours after the last fit. Do not stop magnesium sulfate very quickly. And remember the woman that we were talking about, once her fits were controlled, the mother-in-law took her away from the hospital against the medical advice, thinking that she had a fit because there was some problem, some soul had been on her, which jinn aa gaya, bhoot aa gaya, and then she took her to some faith healer, and we were given the news that she died 3rd day after taking away from the hospital. Another very important thing is that do not use diazepam, because previously we used to use diazepam, I think about 10-15 years back, and there were lots of death because of respiratory depression. So diazepam, phenytoin, or any other anticonvulsants as an alternative to magnesium sulfate should not be used because of the fear of the magnesium sulfate levels. So careful attention to the clinical monitoring is important. Listen, it is not possible for us to have magnesium sulfate levels in our hospitals. In the best hospital setting, it takes 2 to 4 hours for the magnesium level to come up. So clinical monitoring is very, very important. And deep tendon reflexes, patellar reflex is the first to go or to be depressed. Respiratory rate, if it is less than 18 breaths per minute, and urine output has to be monitored every hourly, because magnesium sulfate 90% is excreted from the renal source. So urine output, if it is less than 30 ml, is a risk factor. And if the woman is monitored appropriately using these clinical parameters, then it is not necessary to have magnesium sulfate levels. However, the magnesium sulfate, a concentration of 1.8 to 3 millimoles, is suggested for that as a level for the treatment of eclamptic convulsion. The first warning sign of impending toxicity is loss of patellar reflex, and magnesium sulfate would be more than, the level of magnesium sulfate in the blood would be more than 3 millimoles. Respiratory paralysis starts from 5, and cardiac arrest starts at 12.5. So there is a big difference in the level, and clinical monitoring therefore is suggested in the absence of magnesium sulfate availability. Beware of postpartum eclampsia, because this is the place where we usually flounder, especially if the woman has given birth to a male child. Everybody is busy with the male child receiving congrats and giving congrats, and they forget the woman. And so is true for the hospital staff. They are now less vigilant once a woman is delivered. So postpartum eclampsia is the reason for the maternal deaths in most of the settings. So postpartum blood pressure monitoring at least 4 times a day while the woman is inpatient, and every 1 to 2 days for up to 2 weeks. And reduce the treatment, antihypertensive treatment, once the blood pressure is around 130 to 80 milligrams of mm of mercury. Recommendations about antihypertensives and breastfeeding. This is one of my last almost slide. The use of enalapril is better than captopril or any other ACE inhibitors because it is given in once a day dose. And same is true for atenolol, because in pregnancy we prefer labetalol. But during breastfeeding, atenolol, if beta blocker is needed, atenolol is better because it is given in once or twice a day dosage as compared to levodopa, which needs frequent dosaging. And careful follow-up of the infants for possible signs of hypertension. So commonly young women after hypertensive pregnancies are lost to follow-up once their hypertension resolves. So heightened surveillance, more aggressive therapy, and postpartum follow-up may decrease the future burden of cardiovascular disease in women in later life. So in conclusion, in view of early asymptomatic nature of raised blood pressure, women who are at risk of preeclamptic toxemia should be carefully and appropriately monitored for rise in blood pressure to avoid the risk of eclampsia, stroke, and fetal compromise. And there is an association of maternal hypertension with offspring blood pressure and cardiometabolic health. So if you don't take care here, you have to have the consequences here. And it is important from a public health perspective, as early identification and intervention may ameliorate subsequent cardiovascular morbidity and mortality in women. So a bad start lasts a lifetime. So online classes and online lectures are always risky. So please be judicious in whatever has been said. Once you, especially the undergrads, the postgrads, and the new doctors, they start administering the drugs that have just been said. With this, I would like to thank for your attention, and a special thanks to PSIM, its team, and Professor Azizur Rahman. Thank you very much once again.
Thank you so much, ma'am. Now we have next lecture on hypertension and eye by Professor Zahid Kamal Saab, but I will request respected Professor Zahid Kamal Saab as our next presenter. Professor Masood Sadiq Saab has to go on some emergency meeting. So I request Professor Zahid Kamal if he allows us to postpone his lecture, and so we can give lecture to Professor Masood Sadiq Saab. Can I get permission from Professor Zahid Kamal Saab?
I think he's not on board anyways. SLMC is, we can't see him SLMC. Or perhaps,
Professor
he is here. He is here.
Professor Zahid Kamal, Professor Masood Sadiq has to go for an urgent meeting. Can we give him a chance first to speak? If it's okay.
I think we lost the connection, and I'm reconnecting again. If everybody can hear me, first of all, I would really like to thank the organizers for giving me this opportunity to speak to primarily an adult audience, I believe, not a pediatric audience. I think the conventional wisdom about hypertension in children has been that it's a very rare disease and is invariably associated with renal disease. But in reality, I think the essential hypertension, now it's clear, is no less common than secondary hypertension. And we shall not be missing other causes, in particular coarctation of aorta, which we see not uncommonly. And a typical patient which has evolved over the years is a healthy adolescent with obesity and combination of cardiovascular risk factors associated with obesity and family history. And I am seeing one adolescent in my clinic or in the hospital almost every day. So the reality is that it's not that uncommon as that it has historically been thought. Now, I would start with this Chinese proverb. I think some of you might have heard, encased in fat in youth, encased in coffin in middle age. And I think all of us know that obesity is a major risk factor for various diseases. And I think childhood obesity now, with the lifestyle that we have, is becoming a real big challenge to the next generation. Why do we concern about hypertension in children? Because I think the blood pressure tiles tend to track from infancy to childhood. And we know that this blood pressure in higher tiles in childhood tends to persist during adolescence age. And children with family history of hypertension are more likely to track as an adult with hypertension. If we look at the data from within our own country, I think we know that the prevalence in Pakistan is fairly high. And I was looking at slides from Bilal and other people, and when you people show slide, you start from age of 20. And I think we tend to forget that there's a big age group, which is more than 47% of population, which is under 20 years of age. And I think the prevalence of hypertension under 20 years of age, as late as done a few years ago by Rahman and colleagues, was actually 3%, which for a population like Pakistan is a huge number. Now, how do we define hypertension in children? I think for pediatric age group, you need to remember that everything relates to age, sex, and height. So whenever we define hypertension, we will take it normal if it's below 90th centile for child's age, sex, and height. And we call it pre-hypertension, as you do in adult age group, if it's above 90th centile, but below 95th centile. But the only thing is, we have to remember it from newborn till 16, and it keeps on changing with every age group. Stage 1 is more than 95th centile up till 99th plus 5 millimeters. And of course, stage 2 hypertension is more than 99th centile plus 5 millimeters of mercury. Now, if we look at the normal blood pressure data, I think every country needs to have their own blood pressure data. And that's true for Pakistan as well. And I think we're very fortunate that National Health, the data which we collected in mid-90s, which was actually reported in different journals worldwide and compared with the rest of the world, we fortunately, in that data which was collected, 5,641 subjects were between 5 and 14 years of age. And from that data, we know that in our age group or in our population, the systolic and diastolic, both blood pressures are higher in Pakistani population as compared to the rest of the world. So for us, the definition of hypertension should be based on these values rather than the charts which are actually provided in the books. So what is hypertension in pediatric age group? I think most of you would know what a blood pressure of a newborn is. It's only in 60s. When the baby is born, it's only 60. The maximum rise in life occurs in first 4 to 6 weeks of life, when it goes from 60 to 95. And that's the 95th centile at 6 weeks of age. And from there onwards, the blood pressure rises by 1 millimeters of mercury almost a year. And so if you have a blood pressure of 95 or 100 at 2 years of age, it takes you another 20 years before your blood pressure goes up to 120/80. I think Alan gave a very nice formula that what you can do is, if your blood, you actually put your 100 plus 3 into age in years, and that gives you an idea what a blood pressure would be and how would you define hypertension in pediatric age group. So this is something which I think we often forget when we are looking at pediatric age group, that every age would have a different formula for measurement of blood pressure. Now, this is a very big chart, and I think nobody can remember that chart. That's why I thought it's easier to remember how do we measure. But actually, 99th centile for a 1-year-old is 105. But for a 10-year-old, it's 115. And that obviously will keep on changing depending upon your height, age, and sex. Would be different for males and different for females. The second most important thing when it comes to pediatric age group is the selection of the cuff. We don't keep pediatric cuffs in our clinics or in our outpatients. And most of the pediatricians often do not have more than one pediatric cuff. So what is important to remember is that an appropriate cuff size should have a bladder width that is approximately 40% of the arm circumference. And the length should be 80% covering. Now, if it's underestimated, if it's shorter, you will overestimate. If it's longer, you will underestimate. And that's the biggest mistake in pediatric age group, because people do not have the appropriate cuff size, and they would try and measuring blood pressure either with an adult size cuff or with just one pediatric cuff, which is not good enough to measure pediatric age group. And you can see for each age group, we have our own cuff. There's a newborn cuff, there's an infant cuff, there's a child cuff, there's an adult or regular cuff, and of course, you have a large adult cuff as well. In pediatric age group, we need to have all 4 of them if you really want to measure an appropriate blood pressure in a pediatric age group. As I said earlier, in majority of children, there's an etiology. In pediatric age group, we do not label anybody as essential hypertension unless we have excluded fundamental causes of hypertension. And as you can see, they keep on changing. For a newborn, it's renal vein thrombosis or congenital renal anomalies. Coarctation always remains. Under 1 year, coarctation becomes the most important etiology for hypertension, followed by renovascular disease or renal parenchymal disease. As you grow into pediatric age group, again, renal parenchymal disease becomes more important, and so does renovascular disease, and coarctation of aorta becomes a less common etiology. And so on. As you grow older, your pediatric age group causes primarily are 3 folds: renal parenchymal disease, renovascular disease, coarctation of aorta. If you remember these 3, you actually are covering 90% of pediatric age group hypertension. How do we evaluate in pediatric? It's no different from adults. But I think one thing to remember is the younger the child, more severe is the hypertension and more likely is there an underlying cause. So in pediatric age group, you never assume a patient as essential unless proved otherwise. So we go by history. Of course, if there's a birth asphyxia or umbilical catheterization, any history of renal involvement, endocrine, drugs, and of course, very important family history in terms of not only essential hypertension, but coronary artery disease, polycystic kidney, congenital adrenal hyperplasia, and neurofibromatosis. In pediatrics, the first thing we do is we measure height and weight, and we see whether the child is growing or thriving appropriately or not. If it's under 2 years of age, we will measure the head circumference as well. So growth pattern is one of the fundamentals. Of course, we will look at body habitus, pallor, edema, whether there's a moon phase, truncal opacity, flushing, sweating at rest, thyroid enlargement, all those things which you would do as an adult physician as well. One thing which not many adult and pediatric physicians often miss is femoral pulses. We have reported the largest series of stenting in coarctation of aorta worldwide because we miss our children. And because they're coming in adult age group and we have been stenting them, we have one of the largest series of stents in coarctation of aorta worldwide only because we miss them. Of course, in abdomen, you will look for epigastric DUI, neurologically hypertensive fundoscopic changes, Bell's palsy, neurological deficit. The diagnostic workup in pediatric age group is no different from adults, except that our focus is to find a cause, to find an etiology. And the focus is fundamentally on renal function. Urine analysis, protein creatinine ratio, renal ultrasound. This is the baseline. Any child coming with hypertension would need these investigations done. ECG, chest x-ray, of course CBC with differential because you want to rule out anemia consistent with chronic renal disease, and of course electrolytes, blood urea, nitrogen, and creatinine. What is very important in pediatric age group is actually echocardiography. Now, echo is not only to make a diagnosis of coarctation, as you can see in this particular echo picture, which is showing a classical severe coarctation of aorta with classical Doppler pattern of coarctation, but also to evaluate end organ damage. You want to see if there is left ventricular hypertrophy or any other sequelae of long-standing or acute hypertension, which can lead to, we have one of the largest series of post-hypertension cardiomyopathy. And our data is over 100 now at our children's hospital follow-up. So you can imagine how often hypertension is missed in pediatric age group and people present with hypertensive cardiomyopathy. Management in pediatric age group is, again, I think you need to address the underlying cause and correct it. Because unless we look for it, we are likely to miss it. Of course, if it's coarctation or renal artery stenosis, you can go for an interventional treatment. But if it's a severe renal vascular hypertension, renal segmental hypoplasia, or a coarctation under 1 year of age, or a complex coarctation, you would need surgery. And that would be true for Wilms tumor or pheochromocytoma as well. In pediatric age group, the indications for drug therapy are very limited. It's not something which we start with. We start with, of course, you have to give something because the child has come in with severe hypertension or hypertensive cardiomyopathy, and no essential hypertension does not lead to cardiomyopathy in pediatric age group. So if you see that, if you see severe left ventricular hypertrophy, try and find a cause. And if you can find a cause and treat that, that's the treatment of hypertension. But of course, all non-pharmacological treatments would apply to pediatric age group as well. And with the advent of smartphone, laptops, inactivity, that's particularly true in pediatric age group, we are seeing more and more children with hypertension than we used to see historically 10 years ago or 20 years ago. So I think family-based interventions are key to success. You can't ask a child to lose weight. The whole family has to be involved in that fundamental concept, because unless you do that, you can't convince the child that he needs to lose weight or do a regular physical activity. If the parents are sitting on a laptop or a smartphone all day, how is child expected to do otherwise? Drug therapy, of course, symptomatic hypertension, secondary hypertension, hypertension with target organ damage, diabetes, although relatively rare in pediatric age group, and of course, hypertension that persists despite non-pharmacological measures. So there's a very small subgroup of patients with essential hypertension where we actually give them drug therapy in pediatric age group. That's why when we look at the drugs being used in pediatric age group, the experience is extremely limited. There are only very few drugs which have been tested in pediatric age group to be given to children, particularly when it comes to children under 12 years of age. Our first line therapy again is either ACE inhibitors or ARBs. Of course, calcium channel blockers, diuretics, and beta blockers unless you're asthmatic, an athlete, or a diabetic. Our treatment in terms of secondary hypertension or emergency hypertension, which we see not uncommonly in pediatric age group again, is primarily based on nitroprusside and furosemide. We don't use sublingual nifedipine because it's no longer recommended for acute hypertension. I believe it's no longer recommended for adult hypertension as well, but certainly not in pediatric age group because deaths have been reported with sublingual nifedipine in pediatric age group. So the drug of choice is either we go for IV diuretics, nitroprusside in a dose of 0.5 to 1 microgram per kilogram. You can go up to 10 microgram per kilogram per minute in pediatric age group. The other drugs, when it comes to ACE inhibitors, the only 3 ACE inhibitors which we use in pediatric age group, the maximum experience is with captopril. Lately, we have some experience with enalapril and lisinopril as well, but the majority of children who go on antihypertensive treatment in pediatric age group go on captopril. We use 0.1 milligram per kilogram as a test dose. We admit these children in a hospital setting, make sure that they don't drop their blood pressure significantly. And once we are sure that are confident that they are okay, then only then we put them on captopril. Of course, enalapril and lisinopril are also used in pediatric age group. In terms of angiotensin receptor blockers, the only drug which has been tested and is recommended in pediatric age group is losartan. Of course, the adults have far more experience of losartan as compared to pediatric age group, but this is one drug which we have used safely as first-line therapy in patients with pediatric hypertension. Calcium channel blockers, of course, the 2 drugs which we use in pediatric age group are either amlodipine or nifedipine. We use IV drugs as well in certain situations, but I think the patient characteristics, chronic obstructive lung disease, bronchopulmonary dysplasia, diabetes, hyperlipidemia, peripheral vascular disease, or post-renal transplant. Beta blockers are used more in pediatric age group, I believe, than in adult age group for hypertension, because we are commonly using them in patients with coarctation of aorta or other patients who come in with systemic hypertension in pediatric age group, unless they are, of course, asthmatic or they have a clear contraindication. Again, the experience is limited because the only two major drugs which we use in pediatric age group are either propranolol or atenolol. Diuretics we use very frequently in children, of course, furosemide, spironolactone, or a combination, or amiloride in certain situations. Transcatheter therapy is not something which is uncommonly used in pediatric age group. The most important condition where we use them, of course, is coarctation of aorta, and that's classically done in children over 1 year of age, where we use balloon angioplasty. And if they are adolescents and adults, then the treatment of choice at the moment is stent implantation. Of course, you can do that for renal artery stenosis as well. You can see on the screen, this is a patient with severe coarctation of aorta. It's in a 10-year-old child. You can see balloon being inflated for this severe coarctation of aorta, and post-angiogram clearly shows a very nice result with complete alleviation of the gradient and relief of coarctation. Of course, we all know that the major problem with ballooning is recoarctation, because they tend to recoarc. And these days, if the children are over 35 kilograms, we use stents, different types of stents in these patients very successfully. And I think the results, long-term results of stenting in coarctation, particularly in adult age group, are excellent. And this day and age, majority of adults, if they come in with coarctation, the first treatment of choice is actually stenting. I think you can go on, because pediatric age group per se is a full subject, but I would like to close here by saying that I think we should make it a point that blood pressure is checked in children, because that's not a routine. It's physician's office, school physical, sibling of hypertensive parents. Parents come to you with hypertension. If they come with a child, please check his blood pressure as well, or her blood pressure as well. Of course, low birth weight babies or all teenagers, there has been a call that there should be a national screening of pediatric age group. Age-adjusted population BP centiles. So two fundamental things. One, we need to know what is normal blood pressure for a child, and what method we are going to use, particularly what size cuff we are using. So it's important to keep all cuffs if you're going to look after these children with hypertension. And remember, the younger the child, more severe the hypertension, more likely is an underlying cause. And always remember renal parenchymal disease, renovascular disease, and never forget coarctation of aorta. You will be surprised as how many children with coarctation of aorta are often missed. And I think because we know that tracking of blood pressure occurs, so if you see an adolescent, a 12-year-old, 15-year-old with hypertension, take it very seriously. Hypertensive children are hypertensive adults. And if we can change their lifestyle and do family intervention at that age, I think we can prevent hypertension in these children rather than treating it. Thank you very much.
Thank you so much, Professor Masood Sadiq Saab. Now I would request the last presenter, respected Professor Zahid Kamal Saab, to deliver the lecture. And I'm highly thankful for getting the chance to Professor Masood Sadiq Saab. Professor Zahid Kamal Saab is principal ophthalmologist and laser surgeon and expert in laser surgery.
Thank you very much, Bilkis, for inviting me, and Professor Aziz, my teacher. I had great revision of hypertension today, and I believe that it's a very good step that you have continued medical education despite all the difficulties we are having. And I would especially appreciate that you are doing.
So we
can't hear you.
Can't hear you, sir.
In the interdisciplinary education, which means that as well. Thank you. So next, hello.
So we can hear you now.
Can you hear me?
Yes, perfect.
I would request the somebody who's controlling slides to move it. Yes, this is the normal fundus. Just a kind of revision for you guys as well. That you can see that the smaller branches are the arteries, and the thicker ones, darker colored, are the veins. And that's the normal pattern. However, what happens in hypertension is that either they can develop hypertensive retinopathy, or they can develop optic neuropathy or choroidopathy. Next, please. The next slide. And that's the mechanism, because the arteriosclerosis leads to narrowing of the retinal arterioles and resultant retinal ischemia. And this is how generally it is classified by the Shea's classification. However, you can classify it into mild, moderate, and marked. We would rather classify it by the Keith Wagner's classification. Next slide. Yes. So in this, you can see that the proportion between the arterioles and the venules has changed. The venules are becoming larger, and also where the arteries are crossing the veins, they also start getting changes. Next slide, please. You can see where the arterioles are also getting narrowed, generalized, narrowing. Next, please. And you can also see in the next grade that there are focal narrowing of the blood vessels, arterioles. Next. Don't bother about the different signs. This is very nice presentation here. You can see the graphic presentation that where the artery is crossing the vein, because they share a sheath which is common. So artery being having harder wall, it presses onto the vein, and you can see that the vein, there is banking of the veins. So that means the blood is pooling in the veins on either side. Next, please. This is another way to present it. And you can also see where the artery is crossing the veins actually deflect to the like the 90-degree on the axis. Next, please. And then you can see that the arterioles, the color and reflex from the arterioles change. Initially, it's traditionally called as copper wiring when it is brownish in color, and later it becomes white and it is called silver wiring. That depends on the thickening of the arterioles. Next, please. Next. And this is again a graphic representation. You can see that there is leakage from the blood vessels, and as the hypertension progresses, there may even be edema of the disc. Here there is a bit of catch, because they come with headaches, and sometimes they go to the neurologist and neurosurgeons. And I have seen patients where they did not check, unfortunately, the blood pressure, and straight away sent patient for MRI scans, which, is a bit of a waste of the resources. So papilledema with uncontrolled hypertension is typical. However, initially the visual activity with despite all this horrible swelling of the disc is normal. Next, please. Next. And these are the different variations. You can see that the hypertension with arteriosclerosis and hypertension in mature age and hypertension in the younger age. Next, please. Next. Next, please. So this is the young people. Initially, they don't get any retinal signs, but on the prolonged hypertension, they develop changes in the retina, and especially they also get proliferative changes. And because most of these patients, they have diabetes as well as hypertension, so that makes the diagnosis a bit challenging. But there are ways you can identify, differentiate between the diabetes and the hypertension affecting the retina. Next, please. Slides. Please share these slides.
We lost the slides actually. You'll have to share them again, sir.
So anyway, I would comment that we should work as a team to whenever you want our opinion, you should refer them to us. But also that it is the complementary. When the ophthalmologist look at the fundus and they find that there is edema of the disc, immediate blood pressure checkup and then referral is mandatory. But last but not the least, I would like to say that the presentation conjunctival hemorrhage, spontaneous conjunctival hemorrhage, and because most of these guys, these are taking some kind of blood thinner, so that although looks very horrible to the family and the patients, but it is really not a problem and usually resolves within a week time. However, it gives you an opportunity to retest the blood pressure and liaise with the internal medicine people to find out whether the blood pressure is controlled. And sometimes these patients, they have problem with the stress, and that results in spike in blood pressure and hence a resultant conjunctival hemorrhage. So I would conclude that a teamwork results in good outcome for these patients, and they should always be counseled to have a regular checkup of the blood pressure and eyes. And because that age group is where we in any case recommend the routine checkup every 6 months. Again, I would like to thank you very much for Pakistan Society of Internal Medicine to invite me on this forum, and I would like to continue the research and also continued medical education with Pakistan Society of Internal Medicine. Thank you very much, everybody.
Thank you so much, respected Professor Zahid Kamal Saab, and I am highly thankful for all of the participants and all of the speakers. Now I would request our chair, Professor Hafiz Chaudhry Saab, and respected Professor Bilkis Shabir Saiba for the question and answer session. We have a few important questions which I would request chair and co-chair to please share their experiences. First question is,
I think I would request Professor Bilkis Shabir, who is the co-chair for today, first to give her comments about today's presentations and her views about hypertension course that we have started.
This is a Bismillah ar-Rahman Rahim. Thank you so much, Somia. And everybody can hear me?
Yes,
yes, ma'am.
It was a wonderful amalgam of topics, and I must congratulate Professor Azizur Rahman for it was such a wide extent. We started from children and adults and ended up with the eyes, and it was wonderful, with including all the pregnant females as well. We all know, probably it was discussed yesterday, that the theme of Hypertension Day this year is to know your numbers. So this has been stressed by almost all the speakers of today. Starting from Professor Bilal's presentation, he stressed on heightened surveillance, and this is what we all agree, the reduction of weight and surveillance and prevention. This is no doubt, hypertension is a silent killer, and his stress was basically on the age group and the score. The score he introduced was the bright score he introduced was very brilliant. I think that should be included in the practice of us general internists as well. Professor Sajid Ubaidullah, I don't know whether he is on or not, but his lecture was very interesting and it kept us awake, and I think it kept me, Soumya, and Dr. Shabeen more awake, because he stressed upon the various stress factors, and the fee being the more prominent stress factors. उनके लिए मेरा एक जवाब था उनका मेरे लिए एक जवाब था, वजूद ज़न से है तस्वीर कायनात में रंग, इसी के साथ है जिंदगी का सोज़े दरूं। और सर वो बात यह है कि आजकल तो ये कहते हैं ना कि I refuse to stress myself about things I cannot control or change. So, sir, अब वो females तो बेचारी अब हैं, they are a part of you.
But that was on a lighter note.
That was on, and this is also on a lighter note. And sir, lekin, you had a wonderful, I mean, this was a very important lecture, especially for our trainees and especially for our PGRs who are working on the emergency field, on emergencies and urgencies, the differences, how to manage. That was an amazing talk. But the next lecture was by Dr. Shabeen. Dr. Shabeen, aapke liye hai कि you too, Brutus, you also talked about females who were cruel. Dr. Shabeen, are you there? Dr. Shabeen के लिए है कि Dr. Shabeen, you too, Brutus वाला बात हो गई, that you also talked about women who were cruel to their, daughters-in-law, and maybe this is what actually you come across in your practice. And definitely you said that a pregnant woman is carrying her grandchild in her as well, and a baby is something you carry inside you for 9 months. In your arms for 3 months, I think Dr. Soumya would agree with me, and in your heart until the day you die. Yes, it's very important to focus on hypertension during pregnancy, and the timely intervention is the key to successful delivery and a successful outcome. Our next lecture was by our very respected Professor Masood Sadiq Saab. As usual, sir, it was a wonderful talk. But sir, for you, you said that you are often talking to the pediatricians instead of the adult physicians. I think all people on the planet are children except for a very few. So we really enjoyed your talk. And yes, what I have learned from your talk is that whenever we come across a patient coming into our clinic with hypertension accompanied by children, we should be checking their blood pressure as well. This was very important. And this actually, I mean, I have never done that. And I've learned this from you, that yes, they should be screened out for hypertension as well. We usually go the other way around. But yes, children accompanying the patients need to be checked. Professor Zahid Kamal Sahab, we still, we at KE still think you are with us. We never believe that we have lost. You have left us to Sahiwal. It only comes whenever you are on the webinar. SLMC comes under your name. So that is the time we are reminded that you are in Sahiwal. Otherwise, you're always with us. You are still with us in our team at King Edward Medical University. No doubt the eyes are the jewels of the body, and they are the windows of the soul. So we believe in teamwork, as you said. And I'm delighted to share here that when Professor Zahid Kamal was with us at King Edward Medical University, we were holding regular sessions with, in collaboration with Department of Medicine and Cardiology. Sir, are you there? You have been muted. Sir would share with me that we had sessions and we talked about pre-op, peri-op, or operative managements, and there were regular sessions where we were sharing information we were learning from the eye department, and there was a mutual exchange of information. So I think today was an excellent and a very successful session, and I must congratulate Pakistan Society of Internal Medicine and special efforts by Professor Aziz Rahman and Dr. Somia Iqtidar, and a wonderful moderation by Dr. Haroon Bilal. Thank you so much.
Thank you so much, ma'am. Now we'll ask some few questions which are asked by the participants. I have many questions, but due to shortage of time, I will ask only few one. First of all, one of participants asked, what is the importance of diastolic blood pressure? Why we have to treat it more aggressively?
Is it directed to some speaker, Professor Haroon?
Yeah, this is requested to Professor Hafiz Chaudhry sir. I would request Professor Hafiz Chaudhry.
May I respond? I'm Dr. Wasim. Right. If you notice that the time for which the vessel is exposed to blood pressure, it systole and diastole, right? And the systole is 0.3 second and 0.5 seconds. So most of the time, the vessel is exposed to a diastolic blood pressure, and it is or in fact nowadays we don't talk of systolic or diastolic. We usually talk of a mean arterial pressure and mid-range pressure or average pressure, and that is the pressure which is actually to which the blood vessels are exposed. So in that sense, it's during systole it is just one gush of blood, and for 1/3 of the time of the cardiac cycle, it is exposed, and the rest of the time it is this diastolic blood pressure to which this blood vessel. So the mechanical stress of the vessels is more for during diastole as compared to systole, and that's why the diastolic blood pressure is taken more. The second thing is that systolic pressure is more important from a stroke point of view. Those who have isolated systolic apnea, systolic brain, they are more likely to have more strokes, where diastolic blood pressure is more likely to cause coronary artery disease as well as heart failure, and that is more important on that. So this is both are equally important. In elderly, it would be more of a systolic hypertension to be taken care of, and in otherwise. But generally, nowadays we talk of either central aortic pressure or we talk of a mean arterial pressure as a representative of the load which is onto the heart. I hope that Aziz Sab can possibly add to it as well.
Do you have Professor Masood with us? Professor Masood is with us.
Sir, unmute. Aziz Sab, unmute kare.
I think Professor Masood has left.
He's left. Oh, I had the question for him properly. Aziz, thank you very much for inviting me. I
think you can now sum up.
Okay.
As a chair, you can sum up the session, please.
Thank you. I think we had an excellent meeting, and many congratulations. The first, I think, presentation with Professor Bilal, he stressed the importance of the examination of eyes, fundoscopy, and carotids, and examination of renal arteries. I think for me, the left ventricular hypertrophy is very important, and it was one question on diastolic blood pressure is associated with left ventricular hypertrophy. Thicker is the left ventricle, larger is the size of myocardial infarction, and more are the deaths from cardiac arrhythmias. And left ventricular hypertrophy is again a very important cause of heart failure with preserved ejection fraction, which is very important. So don't forget left ventricle. There was a target of 180 by 120. I think it's very important 180 or 120 in patients having a complicated hypertension and emergencies. But there are some patients who are not hypertensive before and they develop, say, acute glomerulonephritis or preeclampsia. they develop these emergencies and urgencies at a blood pressure lower than 180 and 120. I think you have to be vigilant and you look upon the signs of emergencies. If the patient is confused, check the blood urea, look for neurological deficits. And if the patient is breathless, then just auscultate the heart for a new murmur like acute aortic regurgitation and aortic dissection. And again, my MR murmur in ongoing myocardial ischemia and crepitation in heart failure. That is very important in patients that got hypertensive emergencies and target organ damage. And the blood pressure should be lowered slowly, no sublingual captopril, no sublingual nifedipine. I think it's very important. And again, a very important take-home message from Professor Masood's presentation: don't forget parenchyma, don't forget renal artery, always palpate femoral and diagnose coarctation of aorta. It's very important. I had a question for him: how common is resistant hypertension and how common is the hypertension, white coat hypertension in children? I don't know, I have no data, but I think I was interested in that. Hypertension in pregnancy, again, a very important entity. And when I was a student, I learned that aldomate is the drug of first choice, but now I'm happy to see the labetalol and the nifedipine are now at the top, and the aldomate is at number 3. But you should never give ACE inhibitors or ARBs to your patient who are hypertensive and pregnant, because then oligohydramnios and then fetal distress and fetal mortality very common. So do not give ACE inhibitors and ARBs to your patients, and always look for albuminuria, liver enzymes, and also look for signs of fetal distress. So thank you very much, Aziz, for asking me to take this session, and you can add something. Do you have some data about the resistant hypertension in children or the white coat hypertension in children? As physicians, you come across seeing some children?
No, personally, I do not have. But I think it's a good idea to do some survey but we know in adults, most of the cases who are labeled as a case of resistant hypertension, cases of resistant hypertension, they are simply non-adherent, or they are getting sub-therapeutic doses or wrong combinations. So I think first of all, we must identify who are truly resistant cases. And I think the percentage would be less than 10%.
Sir, I just forwarded your question to Professor Masood Sadiq, and he has very kindly responded. He said that it is extremely rarely seen in the clinical practice, but there is very limited data, so we need to work on it.
Okay. Thank you. Thank you very much.
Thank you very much. I think I will thank you, the chair, Professor Hafiz Chaudhry, is an old friend, and Professor Bilqis, and my good friend, Professor Somia, and Sajid Abedullah, and Bilal Muhyiddin. Shabeen Naz, I really liked her presentation. Masood Sadiq I always known him as a very, very good speaker, and he didn't disappoint today, and that was what we were expecting him. Very good, very crisp talk. So it was, I think, very good session, and that is making me more and more convinced that we should have them more and more often. So I think we'll see you, every one of you, tomorrow, and then next year also. Thank you very much, everybody.
Thank you very much.
Thank you so much.
Thank you, Dr. Bilqis, Dr. Somia, Dr. Hafiz,
Thank you so much.
Dr. Aziz. Thank you very much.
Wonderful having you. Thank you so much.
Same here. Thank you very much. Thanks.